Dr. C, just about we saw methyltrate.
Methotrexate?
Yeah, it's things like everywhere. It's for everything. It's like that carbamazepine.
Yeah.
There's some medicines. What do you suggest about those medicines that seem to be like all over the place?
Well, I would learn it in the category that the book teaches it,
Okay.
which is like in the immunosuppressant for autoimmune diseases. There's lots of things that have secondary or even off-label uses. Focus on the primary. I mean, unless the drug is one that we've talked about and it showed up in multiple places. If it shows up in multiple places in the book or in our lectures, then those are valid first line uses. But if there's secondary uses and you're like, really? Yeah, stick with the primary uses. That's a good question though. Alrighty, let's talk about our bowels. You know, what a way to start. That's not what I want. I want acid controlling drugs and all of that stuff. All right, so all of the things. This is actually pretty useful information just because a lot of it is over-the-counter stuff, and you know, just like we were talking about, like cough and cold medicines, and a lot of them are over-the-counter. There's a lot of everyday uses that you will be called upon by your neighbors to talk about. So these are some of the targets that our medicines work on. So obviously our stomach has hydrochloric acid. That's our main acid in there. It's our defense against pathogens, and it starts the breakdown of nutrients. We have specific ones that break down protein. We have mucus, which is our gut protection. And so that's why NSAIDs interfere with the production of that mucus. So that's why we end up with ulcers. So bicarb is kind of the balance. This is the checks and balance, hydrochloric acid and bicarbonate. And if you love chemistry, you can do all these equations to show how it balances out. We talked about prostaglandins and intrinsic factor, but they show up in the gut, in the stomach as well. So lots of things you should know because they're the targets of drugs. So peptic ulcer disease, like GERD is the gastric esophageal reflux disease, is the precursor or the kind of the red flag or the warning sign that you could eventually develop peptic ulcer disease. So it's sort of, you know, you have all of this gastric distress for years, and then finally go get seen, and you know it's progressed to the point you have ulcers in your gut. And they kind of look on a scope like that. If you do an endo rotation, I know if you're at Riverton Hospital for med-surg, you will be in the endoscopy lab for a couple of times, and you get to see all these procedures and get to look at down people's esophagus, and it's kind of interesting. So number one cause of peptic ulcers, and peptic ulcers are like stomach and then duodenum, so not just tummy, is this H. pylori. And so that's what we target. Not everyone is H. pylori. Some people it's because they took a lot of NSAIDs or they're on other drugs that suppress some of those protective mechanisms. The treatment for it is super complicated because of the problem of antibiotic resistances, because people didn't complete their courses when it was simple. And so now it's this multi-drug 14-day course where there's multiple antibiotics taken at different times of the day, plus your like your omeprazole. It's super complicated, but That's how we treat it, and that's the only way to eradicate it. The best way to diagnose this without having a scope is there's an H. pylori breath test. Yeah, it's super cool. I mean, you have to have not taken your omeprazole the night before. Actually, there's a period of time before. They have you drink a certain solution, and then you breathe into a bag, and it's in that inhaled bag, in that bag of exhaled air, that they're actually looking for the evidence that you're infected. And so then after you complete treatment, we wait a little while, and it's good to check again, because what if it didn't get it because of this problem of resistances? So it's kind of sad. A long time ago, we didn't know that putting people in the hospital caused ulcers. It's a stress. It's not just nursing school at stress, like physical stress of being ill. We've talked about stress, increasing blood sugars, and all of these things that happen from a stressor. But we found out that, hey, doing this to people is leading to gastric ulcers. So lots of reasons. These are the explanations, the reasons. Well, now we got smart, and we either give them one or the other category of acid blocking drugs to prevent these ulcers. The problem that we're finding still is that people will leave the hospital, go home, and they'll continue taking these acid reducing medicines that were prescribed when they were in the hospital for prevention, but they no longer need when they're outpatient. And there are consequences from being on a long-term, like omeprazole, which is like the most Prilosec, the generic version of Prilosec. We're finding now that this drug's been on the market for 20 years, that there's issues with absorbing vitamins and minerals. We have problems with then proper bone development. So osteoporosis can be caused by long-term omeprazole use, like 20 years. I would meet people in their 80s who were in the hospital when they were 50, or 60, got started on it, and they're still taking it, and you have no idea why. And they're, they've had all these fractures, and they have osteoporosis now, and not that it's a contributing factor. So these are, I like my G over here, the 3 targets, and this is the most well-known, our antacids, our TUMs, things like that. And then the H2 receptor antagonists, we talked about H1s, which we traditionally call what? The H1 blockers. What does the H stand for? Histamine, right? So we saw antihistamines when we were doing decongestants and antitussives. And the H1 blockers are for those antihistamine effects. Well, and we mentioned, there are H2 receptors as well in the gut. So we go ahead and target those for acid reduction. So let's talk about how they work. So the first way we could do it is just neutralize the acid. Okay, well, that's fine and dandy, but acid serves a purpose in the stomach, right? There's a reason we have acid. We have it for bacterial defense. We have it to break down food. We have it to metabolize drugs. So it's okay for the occasional use, but can you imagine if someone was chewing on these every single day, how you would have issues with you may have that lack of acid may have suppressed your ability to absorb medicines that are being prescribed, and your doses are getting increased and increased. The higher the dose, the more side effects, right? So it's a big problem. Sorry, I'm trying to get some. So all of these, aluminum, magnesium, calcium, and sodium. Well, do you remember there were some antibiotics that said, hey, don't take it with, don't take your antibiotic with aluminum or calcium or magnesium. So these are some offenders that people don't think about. Like you are doing a med review and patients think you're talking about prescription meds, and so you're going through it all and everything looks fine, but really they go home and their cupboard is just full of this stuff. And now they're on tetracycline. And so before they have their antibiotic, they say, oh, I know it's going to make my stomach hurt. I already have stomach issues. So let's take 4 or 6 Tums, which is calcium carbonate. Then 10 minutes later, we'll pop our antibiotic. Well, now you have calcium and tetracycline together. I mean, there's just lots of issues with it. A lot of our over-the-counter antacids are combined with simethicone, which is an anti-gas drug. You know, it's a 2 for 1. And then oftentimes we add magnesium because magnesium stimulates the bowels. That's like milk of magnesia, or magnesium citrate. Those magnesium products are for constipation and they get you going. So we know that calcium and aluminum are constipating, so it's nice if they balance it out with some magnesium. This is what they do, you know. It actually, antacids, I should say. Bicarb helps buffer the prostaglandin. Think about that one. Antacid stimulates secretion of mucus. They're against bicarb helps buffer. I'll think about that one. We'll come back. So what's our goal? Just like with the goal of seizure therapy and the goal of pain therapy, the goal is to reduce the symptoms. We're not curing any disease. Oftentimes that's lifestyle modification, you know, stop eating. Yeah.
Sorry, kind of on topic, kind of not. What is the difference between the magnesium? Is it magnesium sulfate, magnesium citrate?
Citrate. It's just these different formulations.
It is okay. I was just
Yeah, they're just different formulations. Just like with iron, there's ferrous sulfate, ferrous gluconate, ferrous fumarate. They're just different formulations. Okay. Yeah. Long-term calcium antacids can cause kidney stones. That's a big deal in some people. And then people with renal failure, anytime you see renal failure, always think magnesium. People with renal disease have a really hard time getting rid of magnesium just because of the way that these damaged kidneys function. They're no longer able to switch ions and pee out the excess magnesium. So people can become toxic on mag. Yeah.
Sorry, again.
Yeah.
So when people are pregnant and they get the preeclampsia and health, it messes with the kidneys, right?
You know, people with healthy kidneys don't have a lot of worries. It's when we're getting into kidney disease that we're
like super okay. Because
like,
I was like, when you have the preeclampsia and health, they give you a giant bag of magnesium.
Yeah, and your body should.
That's why I was like,
your body should tolerate it fine
okay.
As long as you're heavy. Obviously, if you had comorbidities, if you were a renal transplant patient and only had one functioning transplanted kidney, things would be different.
Okay.
But in the general population, people do fine with magnesium. No worries.
Okay.
And then, of course, anything that's constipating, the aluminum and the calcium products, it goes without saying that if you're already slow, you don't take a constipating med. You as the nurse don't want to have to dig them out when they come to the ER.
No rectal exams.
It's not fun to dig people out. So that's just, yeah. Long use of these acid suppressing drugs, when you stop them, what do you think you get?
I was gonna say, doesn't it? Because it would be producing more when you stop.
Yeah,
to,
it's that
they're
rebound
like, oh,
acidity, kind of like
take it
Afrin, which is that vasoconstrictor. And when you stop using it, you just have this massive vasodilation and you're way more congested than when you started. So same general idea. We do often use Tums as a source of dietary calcium. The calcium pills are often pretty big. Kind of like potassium pills, hard to swallow. So what's the population that might need calcium supplement? Maybe an older population. Well, they may also have issues with chewing, from dental problems, with swallowing due to all sorts of disorders, and the ability to swallow that large pill is a problem. So I have prescribed Tums before as a dietary source of calcium, just not, and it's long term. but not at super high doses.
Like 1 or 2 a day.
Yeah, like 1 or 2 a day. I'm calculating the number of milligrams of calcium. Yeah. Usually, like if you buy a 1,000 milligram Tums, it's like 1. Have 1. Sodium bicarb, that's more inpatient. It's a buffer, right? So you have acid and bicarb. Those are the balances. When you're in the hospital, you may need to balance things, but what happens when you go monkeying around with acids and bases? You can get that metabolic alkalosis. So not cool. Also the key in here is the sodium portion. I'm sure that you can think now what population might be at risk if you're taking a product that is sodium, right? People with hypertension, heart failure, kidney disease, yeah. So lots of, now you're so smart, you can kind of think through this, like, oh, I should probably think about that. So a patient who has chronic renal failure wants to self-treat with an antacid for occasional heartburn. Which is the best choice? Should they take a mag antacid, a calcium antacid, an aluminum antacid, or should they not take any at all? So yeah, so we give aluminum and sodium antacids for people with some kidney disease. You can have stage 1, 2, 3 of chronic kidney disease and be okay, but we tend to hold off on the calcium and the mag because they accumulate. So that's a good one to know, and typically walk yourself through. Oh, anti-flatulence. What's that?
Why is it a brain picture if it's?
Well, how do you know it's a brain? Maybe that's like a
It's a brain fart. Yeah.
Look at that.
Okay, that
The
would make
brilliance.
more sense.
The brilliance of that. So they're pretty effective. They just kind of bind to the gas bubbles in the intestine and break them apart so they're smaller and smaller and smaller. And like you said, they're usually with an antacid product. There's not a lot of side effects from it. They're really a fairly innocent product. Let's see, antacid interactions. So lots of things. You say if you mess with the pH of the stomach, you're interfering with the way that the drug was designed to be broken down. So they give some examples here. Certain medicines are taken at the same time, they bind together. Levothyroxine and iron are an example. Ciprofloxacin and an antacid are an example.
And that's an antibiotic.
Yeah. And that's just, yeah. So, and drugs are metabolized in various places. So it starts in the stomach, continues in the intestines, but there's also this ion exchange within the ureters and within the kidneys. Sorry, not the ureters, within the kidneys. So messing with anything anywhere along the line, we can have some terrible issues. These are super old drugs. So the histamine 2 receptor antagonists, H2RAs, we typically call them. Same goal, we want to reduce the pain. Just like with antihistamines, H1 histamine receptor blockers, we're just blocking the receptor so that histamine, which is released, can't trigger the receptor. So we have to know that it's the parietal cells that produce our hydrochloric acid, and we're binding that. So this is both prescription and over-the-counter. Used to be only prescription. It is the #1 drugs used for acid reflux. This is more of a prescription. This is more of an over-the-counter. This was taken off the market in 2020.
It was taken.
I believe it was contaminants in the product, if I remember right. It was a big deal because we couldn't get enough commodity to give people.
I was gonna say, when I worked in the peds office, that was one of the main ones we prescribed for like babies with the colic rate or something.
Like the reflux.
Yeah, but they're like, oh, don't give that to them now. All the parents are freaking out.
I
They're like,
mean,
"Yeah."
I think it was only in certain manufacturers and I don't know, but it was taken off the market, so whatever. Things that you should know is that smoking decreases the effectiveness of it. So a lot of people with acid reflux, okay, so I should start the other way around. Smokers have a higher risk of acid reflux. Pathophysiology is in there, we won't go over it. So they're already at risk for acid reflux. Now they're taking well, they're not taking Zantac, they're taking famotidine. And it's less effective because of their smoking. So they're gonna take more, but they're still smoking and it's still less effective. They're gonna take more. And then you end up with some of the side effects of the drugs. The best way to take it is 1 to 2 hours before meals. We want to make sure that our acid histamine receptors are blocked so that when you eat a meal, you're not getting this surge of acid and all of that. We have to be careful with this prescription cimetidine. Most times when people are prescribing it, there'll be a red flag if there's an interactive drug because it has this sort of what's the word? Enzyme inducing action that we've talked about with certain drugs. So it's one that we take more care with because of this liver system. We use it, but it's mostly replaced by famotidine. So most of the time people are taking famotidine. Awesome drug. Okay, let's talk about an old patient. Okay, working with an older patient who's been admitted to your floor for possible GI bleed. Which drug has the potential to cause confusion and disorientation in older adult population? This is something they like to do now. It's one of them. Let's see, this is what they say. Oh, I don't know, but no, it's because it has come up in some of my reading of test questions, just sort of review questions. For some reason, they like you to know that. So if you see famotidine, it's hard because older adults who are in the hospital are at risk to be acutely confused. Anyway, if you are an infection and you're an older adult, you're at risk to be acutely confused. So it's hard to pick apart, but for test purposes, just remember him going. Proton pump inhibitors are super, I think this is the coolest invention. So acid production, hydrochloric acid is the proton, right? And we have a pump that produces it out, right? We're producing hydrochloric acid. So if we turn off this pump, it's like turning off the water faucet in your bathroom. You turn it off, nothing more comes out. Well, that sounds pretty good for people who have like bleeding ulcers or they have H. pylori ulcers that we're trying to heal, or you have the occasional issues, you know, you're going to go eat a big fatty tomato-based spicy meal and at a family reunion or whatever, and you want to not suffer the consequences. So these are great drugs. That's why they're called proton pump inhibitors. It turns off the proton pump, no more acid.
That's cool.
Yeah, it's pretty cool. So, but yeah, the problem is you need acid for lots of things. So these are the over-the-counter ones. These are omeprazole, yeah, it's over-the-counter. They used to all be prescription. Omeprazole is the most common. Pantoprazole is the next one. And then these other ones, less common, but still used. Like if you fail the highest dose of one, you might try another one. They're like cousins, you know, if you date one cousin and you don't like them, you might date the other cousin. Isn't that how we do it?
I've dated all the cousins.
Is that how it's done in Utah? You're like, one of the cousins. I don't know. So it truly does block all of the hydrochloric acid secretion. And these are the indications for it. So if you have reflux intermittently, it's great to use. erosive esophagitis. So if you have something, lesions in your esophagus because acid is refluxing up there, that's a great one. We use it short term for the treatment of ulcers. We use it short term for the treatment of NSAID ulcers. So while the ulcer is healing, we turn off the acid. Once the ulcer is healed, we stop the medicine and resume normal acid. Again, that's in the hospital. Stress ulcer prophylaxis with H. pylori, which is given with antibiotics. So I think it's a really, like, how did they come up with that? That was super interesting. People do well with them, but now, as I mentioned, over time, we figured out, oh, they're not so innocent. I guess we should take people off of them if they don't have a clinical indication. We feel like it's a risk factor for the development of C. diff. Because we're no longer maintaining the correct amount of acid in our gut to pass into our intestines, we may get an overgrowth of an undesired bacteria. So that's not so cool. I mentioned osteoporosis from not being able to absorb minerals. I don't understand this one particularly. There's an association. We're not sure if one causes the other, but they do talk about it. If somebody comes in the hospital with pneumonia and they happen to be on an omeprazole and they've been on it for ages and the patient doesn't know why they're on it, they will automatically take them off in case that was contributing. And of course, you can't absorb magnesium. A lot of these are associations. So there's some association between like omeprazole and dementia. That's not well established. That's like saying there's an association with, you know, the number of lights on in a building and the number of students in the classroom. Well, people may just keep the lights on in the building 24 hours a day. Just because you find out that two things happen at the same time doesn't mean one causes the other. So that one is pretty neat. These are the drug, some of the big drug interactions. So phenytoin, our favorite phenytoin that interacts with everything, our favorite warfarin, our favorite digoxin, all the big ones, right? All the big ones have an interaction with these proton pump inhibitors. The way that these ones are taken, so what's normal physiology? You eat something, when it hits the stomach says, oh, there's food. Let me open the faucet and have some acid. That's normal physiology. Well, we don't want that acid with our food, so the best way to take it is 30 minutes before you're going to eat. Why 30 minutes? Why not take it with your meal?
Because of the onset.
Yeah, you need some time for it to be absorbed, because it's not like having its action like it's not like an antacid where the action is just opening here. It has to be absorbed through the GI, has to go through the first pass. I mean, it's a process. So then when somebody eats and the stimulation, oh, the stomach is like, oh, I need to turn on the acid, but hey, you know, that's been shut off. There's a lock on the acid. So that's what you should teach people to get the best bang for their buck. If they're going to take it, might as well take it right. But people don't, you know, they just dump all their pills together. Down they go. Can you imagine if you have to take your thyroid hormone at this time, early in the morning on an empty stomach, and then it's the day that you take your alendronate, which is your Fosamax, which is your osteoporosis medicine. And so you have to take that on an empty stomach and sit upright with a full glass of water for 30 minutes. And then you need to take your proton pump inhibitor. So make sure, because you want to eat breakfast to take the rest of your pills, but you need to take the proton pump inhibitor now, and then wait 30 minutes. And it's unrealistic, but we need to learn what the recommendations are. Real life gets in the way. Some of the things about pantoprazole, you can give it to through the NG tube, but you have to have a really wide bore NG tube. You do open, these are delayed release granules in there. So the granules themselves have a coating in there so that once they're in the stomach, you don't have a slam of medication. They're slow release. They do tend to clog tubes, but what are you going to do? You got a patient who's got an NG tube in the hospital. We're doing stress ulcer prophylaxis, they need their proton pump inhibitor in order for them not to develop a stress ulcer. So you do what you gotta do.
Didn't you flush the NG tube?
You do, but
Yeah.
it's not perfect.
Yeah.
Like stuff gets stuck. It just is, you know, a little tube, and I mean, even though we say a large bore tube, it's still pretty small. You're going down up somebody's nose and down. It better be small. Perhaps the contents, yeah. So that's why they do get open. This one is basically like putting wallpaper paste on your stomach. We're just coating the inside. You love it? Yeah. So this is our, I don't know what that was. It's like the Hulk or something protecting you from a mucosal ulcer from the gastric acid. So it's another way to short-term prevent gastric ulcers, right? You just are, it's like taking a paintbrush and painting your stomach. So we use sucralfate, or Carafate is the brand. But the problem is, of course, if you're coating the stomach, then if you take your medicines, it's going to coat your medicines, and then your medicines are not going to be effective. Yeah, so that's why there's this little caveat about drug timing and the medication. And if you just know it's because of how it works, it's this wallpaper paste in your stomach. It's, you know, it's gooey and sticky, and if you put your meds in it, well, they're all nice and coated down, and they're protected, and they're not going to break down. And they can be constipating. Just you know, wallpaper paste in your gut might bind you up.
I think it's better than C. diff.
It's better than C. diff. I mean, I haven't had C. diff, but having taken care of it, it's better than C. diff. All right, misoprostol, you probably maybe have seen it on the news for other reasons related to pregnancy and all that, but we do use it for NSAID, risk reduction in NSAID-induced ulcers. Remember, we say there are people who have to stay on NSAIDs. If you have a chronic inflammatory disease, steroids are too harsh. You can't, I mean, you can be on a lifetime because transplant patients are. But if there's something that's less harsh than being on prednisone for the rest of your life, we'll choose something like that. It does encourage the damaged cells also to heal. It promotes blood flow to your gastric area. So if you do have an ulcer, it can heal. You need blood flow for healing, right? This is the caveat. Doses that are high enough to treat ulcers often give you the diarrhea and abdominal cramps. So, you know, nothing is innocent, right? Everything comes with the price you pay. All right, simethicone, which we talked about, is often combined with calcium carbonate and acids because of what effect? And there's only, I got rid of D because it was a stupid answer. Narrowed it down. Simethicone, when you combine it with an antacid, do you get an increased antacid effect? Do you reduce gas? Do you reduce diarrhea caused by calcium?
Reduce gas. That's what it's
Right.
for, right?
Right. That's exactly it. So it's asking you, do you know what simethicone is for? And here they even are giving you the opposite of what calcium does to see if you know what a calcium antacid is at risk for. So that's a 2-4. Down here, we know that calcium doesn't cause diarrhea. Calcium is a constipator. That's the description of how simethicone works. All right. And this is one of the reasons why, besides malabsorption of drugs and risk for osteoporosis and all of the problems that come with long-term use, people who self-medicate can actually be hiding malignancy. They may have gastric cancer. They may have ulcers in there. So people who self-treat think they're doing a great job, but if you're taking something long-term, you probably should encourage them to find out why they're having constant stomach pain or constant acid. Something else could be going on that needs to be evaluated, fixed. And some of the fixes are great, they're permanent fixes. You have H. pylori and you cure it, well, then you're cured. Of course, you can get it again, but you're cured at that time. So yeah, people don't want to, after 20 years of taking it, find out, oh, I had a gastric cancer that could have been diagnosed a long time ago. Okay, you're giving education regarding the use of what's PPIs? Okay, proton pump inhibitors. Which statement will you say? Take the medicine along with the first meal of the day. Take the medicine on an empty stomach 30 to 60 minutes before eating, or take the medicines when you have symptoms of something. Yeah, obviously. That's the tendency. What really happens, that's the recommendation. Yeah. Oh, and they are typically not an as needed, but we do some, I mentioned we do sometimes talk about this. If you know you're going to have acid when you're going to eat a big meal, go ahead and have one. All right, that was all of the antacids. Let's talk about the runs.
Yay.
All right, so definitions. So this is know your time frames, because they like to throw time frames into EdPlex style questions, saying whether patients had diarrhea for a week or whether a patient's had diarrhea for 3 weeks. So knowing whether this is an acute issue or if this is a chronic issue, because typically acute issues are much different than the chronic issues, right? We have a GI virus, we have some sort of, we ate salmonella, contaminated food, and it comes from the antibiotic we took. We traveled overseas and went up in the mountains and we drank the water, and now we got the squats. And these are things that can be addressed. This is symptomatically, there's treatments for this. If we happen to have C. diff, there's a treatment for that. So chronic diarrhea is usually caused by a long-term condition, right? So if we have hyperthyroidism, why do you think with hyperthyroidism? What does the thyroid gland do? Remember back to talking about thyroid?
Regulates our metabolism.
Yeah, it's kind of that master control system of how fast things are happening. So people who are hypothyroid, if you remember that image of weight gain and feeling sluggish and constipation and bradycardia, well, if they're hyperthyroid, it was weight loss and tachycardia, and bowels are overstimulated. So people don't think about it, but that is one. Diabetes is a risk. Irritable bowel, of course, there's two types of irritable bowel. There's irritable bowel with diarrhea and irritable bowel with constipation. People who have Crohn's disease, people who have AIDS. There's a lot of chronic conditions. Oh, what is that? Oh, she's really having a hard time. So our goal of diarrhea treatment, obviously, if it's infectious, we want to treat. If it's a bacterial infection, we want to treat that. But other than that, we're treating symptoms. We're trying to, same like acids, we're trying to treat symptoms. So our goal is to slow the flow, get rid of the abdominal cramps so that we're not losing fluids and electrolytes. We're not having nutritional deficits. And these would be more for those chronic causes of diarrhea. You have Crohn's disease or irritable bowel with diarrhea. These are the risks that you can, and anybody who's met a mom with a kid who has vomiting and diarrhea, it's the Pedialyte, worrying about them becoming dehydrated. We all can. So for diarrhea, again, here's same idea as with acid. When we coat the stomach, well, we have ways to coat the walls of the GI tract. And so they're called adsorbents, not absorbents. They're with a D. I like to think that we're adding something in there adding something to protect, but the problem with the addition is that we get bound up. So this is Pepto-Bismol, activated charcoal. That's not very common. Pepto is the big one on the market. Problem with Pepto, besides it being constipating, it has, people will have black stools. And then because Pepto is a salicylate, where did you see salicylate before?
It's aspirin.
Aspirin, right? So anytime you have this salicylate, you're at an increased risk of bleeding. So long-term use, again, not such a great thing because increased risk of bleeding, and people get all freaked out and say, I have a GI with dark stools, I have a GI bleed. So that was the adsorbents. Anti-motility drugs are pretty extreme. They are prescription drugs. We're generally trying to slow the stimulation in the GI tract, all those nerves that stimulate peristalsis along the tract. We're trying to work with acetylcholine receptors. So they're anticholinergics. Acetylcholine, over here, parasympathetic nervous system, right? To slow things down. This is atropine and hyoscyamine. These are, they're also used in palliative care for people who we're trying to dry up secretions just for comfort, but recognize atropine shows up again, and we've seen atropine before along the way. All right, oh, these are the side effects, everybody knows them. We should know them all by heart now, right? Anticholinergic side effects, we've seen them so much in so many drugs. Then we have anti-motility drugs, so we're still on anti-motility. This is anticholinergic. This is another type. Loperamide is over the counter. Everybody knows it. It's your, what's that? Imodium. Imodium. Took a minute. It's Imodium. We also use codeine. Loperamide gets converted into an opioid in the body. And so that's why it falls under the opiate class. And remember, we're using these medicines for the side effect of constipation, where we're not giving it for the pain relieving, we're not giving it for the sedation, we're giving it for the constipation. So we're using different drugs. But again, they're going to come with some of the same side effects depending on the dose that you're giving. People who have diarrhea, they're just swallowing Imodium like it's candy, you know, they can have respiratory depression if they take enough of it. People who are taking the entire box in a day. And then of course, if you take too much, you swung the other direction. And now you're taking stuff for constipation to get you going. So all of the side effects that came with opioids are still there. This is another one of these new drugs of abuse. Can you imagine? People want to overdose on or see if they can get a euphoria from taking Imodium. Joins the class with all the cough suppressants, and it's a little ridiculous. So these are still questionable. We do it by adding either prebiotics or probiotics. We're trying to give intestinal bacteria back. We now know that our intestinal flora is not just something that's there but has no function. We know that it's every day I read a study about bacterial flora and what they're finding out it has a role in. So we're in the early stages of understanding this, but we know that having normal bacterial flora is critical for many normal body functions. In fact, now we do fecal transplant, right? Where we take fecal matter that we get, you know, processed in a certain way not to kill bacteria, and then it's ingested in order to replace the bacteria in your GI tract. So when we say, tell somebody to eat shit, I mean.
It's actually therapeutic now.
It's therapeutic. See, I do that with the best of intentions, right? The last meta-analysis I found was that it can reduce the duration of, like, if we're using it because we have diarrhea, it can reduce the duration by 1 day if the cause of the diarrhea is related to an imbalance in your GI tract. I don't know that there's any harm. I just don't necessarily recommend it myself. What you do is your business. All right, so that's the diarrhea side. Now we have the constipation side. So people are all stocked up, and that happens in America because of all the foods that we eat. So fiber is like the oldest thing out there, and you hear it in on the news and in health blogs about you need so much fiber, and but fiber is the 2-for-1. I think it's really cool because we use fiber both for constipation and for diarrhea. It's like the equalizer. If you're constipated, you take fiber with a lot of fluid, and it absorbs into your intestine and like this, pulls water into the intestines to soften the stool and to stimulate peristalsis. If you take fiber with the recommended amount of water and you have diarrhea, it pulls the excess water and binds it with the fiber, and now you have normalized stools. So it's an awesome one. Unfortunately, if you take too much, you can end up impacted. Lots of issues with it, but generally it's fairly well tolerated. Taking Citracel, Metamucil, Benefiber, there's all sorts of fibers on the market, or you could just eat a high fiber diet. God forbid. All right, that's bulk laxative. Then, so this one I talked about, we're pulling water into the intestines, we build up bulk. This one is we make everything slippery. If you're constipated, and if we grease up your intestines, basically spraying a little WD-40 in there, it slides on out. So we use emollients and surfactants and lubricants. So mineral oil, obviously it typically goes up the back end, although I've had patients who drink it. They're generally old people, old school, and grew up in Kentucky, and that's what their mom did. And they swear by it. I just think it sounds awful. And then DocuState is a stool softener. It's not a laxative. A lot of people get confused about that. So this is all about making things slippery, moving through. Of course, if we move things through too fast, we fail to get the time in the intestines to absorb, right? That's our key role of our intestines, is absorbing nutrients and water and all of that. So if we make it a little too slippery, it slides out too fast, and then we might miss out on something. But this is fairly innocent. Mineral oil is the least offensive of like the suppositories and enemas and stuff. Well, glycerin is, but mineral oil's up there with it. Surfactant, laxative, all right, we know. Hyperosmotic, all right. Lactulose, polyethylene glycol. So you'll see it abbreviated on a MAR as PEG. And what it means is Miralax. That's the brand name, but it's actually called polyethylene glycol, or PEG. So these are large molecules that stay in the GI tract and by osmosis pull water into the GI tract. And so the bowels get distended. It stimulates the little nerve fibers for peristalsis, and out things go. They're very effective, very effective. So oftentimes at home, people who are super backed up, will say, hey, let's get you on some Miralax, and people often overdose it and then they are squirting out the next day, but they are very effective. So the problem, of course, you can end up with diarrhea because it is going to absorb water into your intestines and make you evacuate no matter what. So it's effective. So we've got all these classes of things to treat our guts. Laxatives, not a great fan of laxatives, but they do have their place. So this is a saline laxative. Again, very similar mechanism of action to cause bowel distension. These are the examples. So if you see magnesium, who are you careful with? People with kidney disease. Magnesium, just think in your head, kidney disease. I don't know how to link them together. I don't have any cute tricks, but magnesium. And so all the side effects that come with it, because they work really well. This magnesium citrate, they're starting to use that now as bowel prep for colonoscopies because it's so effective rather than the Go Lightly, the powder that you mix in a giant bottle. You have to be of my age to know how to. Anyone who's seen anybody who does bowel prep, this mag citrate's only in a bottle about that big. And you drink a quarter of it at a time and whoosh, everything comes out, right? Because you have to be clean to have a colonoscopy, so super effective.
We had a lady in the hospital last week that she had like a gallon size jug of that stuff because she could not get anything out, and she drank a whole gallon of it throughout the night. And there was still nothing, but I was just like,
at some point there
wow,
will be,
okay.
and
I'm
whoever
like,
CNA was
holy
cleaning it up is gonna be, yeah.
yeah, I was like, good thing I wasn't there.
The dam will eventually break, unless there's a physical barrier in there, unless she's got a tumor or that's physically blocking passage of stool, or there's adhesions. People who have bowel surgeries tend to have adhesions where parts of the bowel start to stick to each other and things can't pass. You get strictures. And so if there's a reason somebody can't pass it, we need to figure that out. In an otherwise healthy person, that person will eventually blow, literally, out the other end.
Like, all right, we're sticking a brief on you.
Yeah, I mean,
Just
a
go-
brief
just
or
go take a
hold
shower.
it's like rubber sheets, because there's no chance that person will make it to the bathroom. None. All right, so we did acid, constipation, diarrhea, and now with all that, you feel so happy that you need a break.
Yes,
thank you.
thank you.
You need a snack, because that was so, we're talking about diarrhea, this makes you hungry.
So I started to do this. I felt so good to get out of it. Is there somebody listening right now? You get to be the bad guy sometimes.
Oh, Alex, I have one for you too. Take care of it. I'll break and bring you back to Sanibel. You can ask him 5.
Thank you. I did something like.
No. Proton pump inhibitors are just their mechanism of action is to turn off the faucet of acid production.
Okay.
So those calcium containing products like those are antacids,
Okay.
where they act as a buffer,
Okay.
balancing. So you still have hydrochloric acid production, but you're taking something that's going to balance that acid, that will make it less acidic, more alkaline, have a more neutral pH.
Okay, okay, because with the PPIs, I was like, wait, what, does that cause, that can cause osteoporosis, I was like, how does calcium cause, does that make sense? Doesn't
So
have
it's
to.
malabsorption, right? It's all malabsorption. We need acid.
So, oh, sorry.
Go ahead.
Osteoporosis?
No, so Tums contains calcium.
Yes, okay.
So you still have acid production. Your proton pump is still producing. And we're just neutralizing that a little bit better. And you're taking, that's calcium, and the calcium does get absorbed systemically.
Okay.
Yeah.
All right, that makes sense, thank you.
Yeah.
So, my question is, I take a lot of PPIs too, and it's because I have that, my anxiety turns up my acid, you know, and so I'm like, I live on
Oh, no.
because, you know, nursing
But
so
treat your anxiety.
But you know, I don't have that. It's been 2 years ago. I need to start. But my father has the same thing.
It's not uncommon. Lots of people have those symptoms with anxiety, but it's better to treat the anxiety.
I know. And I even had the endoscopy because my stomach was hurting a lot. The more stress I have, like my parents aging and all of that. And then I had an endoscopy and they're like, there's nothing in your stomach. There's nothing in there.
There is a huge brain-gut connection. That's why the drugs for diabetes and weight loss, the GLP-1s, the Ozempic, the semaglutide, liraglutide, those drugs that are for diabetes that are once a week injection, they work on this brain-gut interaction. It's well known, it's well established. So having stress is a brain thing, but there's a brain-gut interaction. That stress just automatically triggers acid. I used to experience that. I just feel anxiety much better.
Oh, yeah.
But I mean,
I don't like
school does that, and the stress gets worse when you start clinical practice. Because it's all on you now, and people think you know what you're doing, and you're a beginner and you don't.
I better go back to running because running used to be my therapy, but I haven't run. in 2 years.
It just seems like there's never enough time to do everything that you need,
Yeah.
but I mean, I'm a big fan of treating the cause and not the symptom.
Yeah.
Especially if it's like you anticipate it could be for a long period of time, which, I mean, your parents aren't going to get younger. Life is not going to get less stressful for a while anyways. So anxiety is a normal human condition, and excess anxiety is treatable and manageable, and it's like having diabetes or having, you know, anything else. It's a condition that is manageable. You feel so much better when you treat it.
When you drink?
When you treat it. Well, and when you drink. I like drink 2 cents worth. You do you.
Yeah.
Now the weather's gonna start getting good. You can,
Yeah, the winters just kill me. No, the winters are very hard. I'm solar power.
That's what I said to her. My depression goes in our soul.
yeah, winter's
When there's no
awful
sun.
here. Awful.
So do you really think antacids has an increased dementia?
Oh, proton pump inhibitor.
Thank you.
See, I try and figure out, I try and read well, really good studies, and not every study is a good study. Lots of studies are crap. I try and read really good studies, and how do you prove it? Like, first of all, at first I try and think, okay, what would the pathophysiology be? Like, why would turning off hydrochloric acid cause, and there's lots of types of dementia. Now, not that I know everything, I certainly don't. It's not very logical to me, but it could happen. Second, you can't do experiments, right? You can't ethically give somebody a PPI and then give another group no PPI and determine, you know, do you have an increased risk of dementia? What they do is retrospective analysis. They look back. You can never account for everything. I don't know. I just think that dementia is more of a, it's more common now because of, there's vascular dementia, because of all of our hypertension and our hyperlipidemia, because of our sedentary lifestyle and obesity, and so that causes vascular dementia. Most dementias are mixed, having all sorts of components. Vascular is big. Somebody may be unfortunate enough to have a Parkinson's dementia, or a Lewy body dementia, or all these other random types of dementia that we don't know why they happen. And they could be combination of genetics and environment. And then there's Alzheimer's that we still don't understand. Like we thought we knew everything about Alzheimer's. We thought we knew, okay, it's because of these plaques. So they did take a group of people, and there was this drug that came on the market, and they were at high risk for early onset dementia based on family factors. Gave them this drug, followed them over a long period of time, and they didn't develop plaques, but they did develop dementia. So there's other things going on that we just don't know.
That's hard because I've heard so my grandma had Alzheimer's and died a couple years ago, not from it. And they said that it skips generations. Have you ever heard that? No.
I mean, and how do we know it's plain Alzheimer's? People call dementia Alzheimer's because Alzheimer's is a common term, but not all dementia is Alzheimer's. Alzheimer's is, by definition, still what we call that amyloid plaque disease. And the only way to know that that's the type of dementia is to do like imaging of the brain, and that's way too expensive for diagnosis because what are you going to do? We don't have good treatments. Most of it is alcohol induced. There's alcohol causes dementia. Like I say, vascular dementia from a lifetime of vascular disease just happens. So maybe there was a little bit of amyloid plaque in there, but we just don't know. I haven't heard that like Alzheimer's skips a generation. I just know that there's, for people who have legitimate early onset Alzheimer's, they've had imaging, and after they died, they did autopsy and validated, okay, what we see is mostly amyloid plaques. That if you have risk factor for that every generation has the risk for it.
Yeah.
Who even knows?
Well, we were gonna donate her body to the U because that's where she had been going, but they said it would be years before we know anything. And then by the time we got her body back, like it's
And then during COVID, they weren't expecting donations.
yeah, and she died February of 2020. So
Oh,
literally like.
I had a lot of patients who that was their burial plan. Like they were so poor, they had no money for anything. Like no family, no money. Oh, my kids know this. Horse kicked me off a cliff.
That too.
They're done.
I don't even have to smell it burnt toast.
I treat my kids amazing. Go on a trip.
Exactly.
Celebrate life.
But everybody has their values, right?
And that's fine, yeah, like that's fair. It's one of those like,
Thank you.
I guess like going through.
I try.
Yeah.
What was happening, but now it's just like a lot.
Yeah. No, it's completely different. Right? Nothing like, I just got chills.
And being able to be on a market,
I feel almost reverence for that body.
yeah.
Ooh. Who's on my grave is this day Scotland. Thinking about
Body donation. My friend Jess stored she was in charge of like the cadavers that they had at my show said to me, never want to come up here, I'll let you. I'm like,
She's like, I don't know what to do.
oh,
Unless there's a clinical indication, like you should not self-prescribe to treat symptoms. No, you should figure out what's the cause of your acid reflux and treat the cause. Yeah, is the acid reflux avoid things that are your triggers? Is the acid reflux stress related? Then manage your stressors, do things to reduce stress, lifestyle intervention. Is it anxiety related? If there's a clinical indication, like if you have I'm trying to think of somebody who's been there.
my husband, he's concerned.
And it's So people get put on it long term because it treats the symptoms well. But have we gone back and found out why we're having the symptoms?
Yeah, nothing I know. I know, it's a cadaver day. Cadaver day.
But after I had this crisis, I can't really eat a lot of food, so there's too much. I was really all the time for calories. So they're like, yeah, you need to take this all the time.
Yeah, I mean,
Crazy amount of it. Like, I only take like one day, but yeah. Yeah.
I just feel like it's I don't want to be hypercritical. I feel like it's lazy medicine. If I'm being honest.
Yeah, because there's a lot of doctors who are
Don't
like, you're just
quote me
taking
on
this
that.
one day, because they don't want to do work. Actually.
I mean, some people don't want to either. Testing is
Yeah.
invasive, testing is expensive. I get it.
Yeah, I mean, there's that
Right.
too,
But it's like, people don't want to make lifestyle interventions because they're hard. It's harder to avoid
This was their cadaver. Like, it's not right.
And like the Spanish and
They had to learn every single.
I don't know if cultures who eat spicy food don't have that. Yeah, maybe it's just how you live, and that's the way it is, or maybe there's something after that calms it down.
where they were doing like full for a transplant, and it
We're just learning about how it works in a million ways. Wait 20 years, there's so much. Amazing. Science is time.
well, I know, but like, there's a lot of stuff that you can advance in just in like, 5-10 years.
So what about antacids like Tums? You can take those all day or every day, either way, the opposite is too much.
Well, so I mean, the problem with taking Tums chronically is that remember you're altering the pH of your stomach.
Okay, and that affects the cells of our.
Right, you need acid.
Is that something that's like?
I mean, and you need to write down what you eat, and when you have symptoms, we'll see if there's like modern day medicine is not a way to take time. Oh, well. All right, all of that acid stuff makes me hungry. Let's talk about vomiting. Out one end, now out the other. So we don't need to know the definitions. Everybody knows what nausea and emesis is. We just learned the word emesis so that we can know what an anti-emetic is, right? Anti-emetic meaning, that helps with vomiting. Lots of mechanisms of action of drugs to deal with nausea and vomiting. These are all different types of drugs that we use. So acetylcholine blockers, antihistamines, antidopaminergic, prokinetic, and serotonin blockers. Those are like the Zofran type drugs. So let's see what we've got with acetylcholine. Hey, we've seen this before, right? Acetylcholine blocker. We were talking about it for back in the parasympathetic system. So here it is again. We're just talking about it for motion sickness. This is the place that it acts, this CTZ, chemoreceptor trigger zone. Obviously, we found out about it with patients undergoing chemotherapy. That's how it's got its name. It's that patch placed kind of behind the ear. This is where it has its mechanism of action, and that's why it's placed where it is. Motion sickness is the main use. I have used it for a few other things, but it's typically meant to be just a short-term treatment. So that's that one. Antihistamine, diphenhydramine. So antihistamines, we know they have anticholinergic action by preventing the cholinergic stimulation. So all of these products, Dramamine, that's the chemical ingredient in it, diphenhydramate, diphenhydrazine, diphenhydramine, I was looking at meclizine, and then meclizine, which is prescription for vertigo. Let's see, use for motion sickness. It's typically for the vertigo, which is real vertigo, which is not like I'm dizzy, which is like the room is spinning and I have balance issues and yeah, it's awful. So same side effects of diphenhydramine with cough and cold are there for using it for nausea or vomiting. The side effects are the same. Oh, well, antihistamine's done. Antidopaminergic. So these are all prescription. Should recognize the name, or at least when you've been on the floor for a while, compazine, phenergan. Know them by their generics, prochlorperazine, promethazine, and droperidol. Block dopamine receptors. They're also used for, I thought this one was interesting, the psychotic disorder, or the intractable hiccups. That's an interesting use. Let's take a phenergan for intractable hiccups. All right, so what else do we have to say about it? Not a whole lot. Block dopamine receptors. All right. Prokinetic drugs they like to test you on because they do have some long-term potential side effects. Metoclopramide, which is Reglan, is the main drug that we talk about. It is used to stimulate peristalsis. So the movement, that neurological movement down the GI tract from stomach on down. So I've seen it used in quite a bit of cases where people have neurological conditions where they have slow movement down the GI tract. I've seen it in gastroparesis from like diabetes. So that one of the potential consequences of long-term diabetes is nerve damage, and the nerves can be lots of places, not just the feet, but in the gut as well. So you can end up with gastroparesis or delayed gastric emptying. The nerves that stimulate your gut to move are damaged from long-term diabetes. And so sometimes we give a drug to stimulate that movement. The trouble with taking it long-term is it can cause irreversible tardive dyskinesia. It's those abnormal involuntary muscle movements. That's the key with metoclopramide. So we do try and only use this short-term because of the risks. If they do need it long-term, we try and use the lowest dose possible and make sure that they know. And if they do start developing any early signs and symptoms, and they're taken off of this, or they have a discussion that, okay, you can stay on it, but this is going to get worse. So metoclopramide. All right, the serotonin blockers. So those are the ones that we really love the most. Ondansetron, Zofran is like our go-to drug for anybody who comes into the ER who has nausea and vomiting. It's like, well, give them some Zofran. Well, it's not actually the clinical indication. Really, the only clinical indication is nausea associated with chemotherapy. I believe it finally got approved for pregnancy-related nausea.
Yeah, I was gonna say, I took that when I was pregnant.
It used to be off-label. There wasn't an approval, and I think it's approved, but don't quote me on that. But it gets given willy-nilly. Willy-nilly, meaning,
Oh, no, I was just talking about pregnancy.
willy-nilly, you know him? So anything that ends in etron, I think this is probably the only one that would show up, but just recognizing that there are other ones now on the market, because of course they're so popular that drug companies want to get in on the fun. And so anything that ends in that. Definitely effective or helpful for chemotherapy and post-op nausea and vomiting. So you'll see tons of it. Recommendation, of course, is given before you have chemotherapy. Let's get it in the system so that we can minimize all of these adverse effects that we know are going to happen when people have chemotherapy. Some of them can cause drowsiness. We warn people, but I don't know how much of a big problem it is. And then of anything, we don't want to mix it with with alcohol. The main thing is like, when do we give Zofran? When they have symptoms? Oh, cute. Oh, that was the end of that. There was supposed to be a question, but maybe I got rid of it. I think there was a question like, a patient has blah, 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 and what's the correct answer? And one of the options is as soon as they have symptoms, then you give them Zofran, and of course that's wrong. We want to, if we know that somebody is undergoing something that's going to make them nauseous, then we give it ahead of time. Oh, we're going to get through stuff today, and you're going to get out of here early. Approved? Stamp of approval. Yeah. Yeah, student approved.
Okay.
We having a game today or not?
No, Monday is gonna be our review day.
But Monday is our HACCP, right?
No, Thursday's HACCP.
Oh, no, we have a HACCP, but it's fundamentals.
Oh, well, we're just
Yeah.
reviewing on
Yeah.
Monday. Yeah, we're just reviewing on Monday, gonna go through as many questions as we can to kind of go over all, because this is a lot.
Thank you.
54 chapters of content, 56. I expect you to know everything. All right, let's talk about skin and what we should be expected to know. So we know that our skin houses lots of flora, lots of bacteria. The most common ones are strep and staph. They live on our skin. Usually they're very innocent. Usually they don't cause any problems. But when they do, that's when we start to get all of these types of things here. So folliculitis, infection of your hair follicle, impetigo, infection of the skin. Furuncles and carbuncles are just based on the size of the kind of the infectious bubble that you have. Depending on the size, they're called one thing. And then if they're filled with pus, they have a different name. And vesicle, just all names for fluid or pus-filled bumps that are full of infection on the skin. So usually it's staph or strep. And so usually we treat empirically, knowing that most infections are either staph or strep. So bacitracin's out there on the market. Use it for, it isn't antibacterial, right? So long-term use is not recommended. We don't want to develop strep-resistant bacteria on our body. And then when we're acutely ill, or we're immunocompromised, or we have a break in our skin, then we now have a resistant infection. So it's a fine little thing for use. Hardly has any adverse reactions. Most of them are just related to where you put it. But it is, again, short-term. The intention is short-term. We do have a problem with overuse of Neosporin. It is one of the known antibacterials on the market to cause allergic reactions. So people put it on their wound, and then they get this redness and inflammation around there and they think it's infected, and perhaps the redness and inflammation is actually an allergic skin reaction. So it is not necessary to put Neosporin on every single cut and sore that we have. It really is unnecessary. If you choose to do it, do it sparingly, because if you can over time, so either you're a person who's allergic to a lot of things and you're going to have a skin reaction, or more frequent exposure, eventually you may develop an allergic reaction to it. So, I mean, it's on the market because people have fear and they play into the fear, and if I have a cut, I should, put something on it. Well, how about you wash it with soap and water and put a Band-Aid? I don't know. Common sense. You do you.
It's not common to me. I put Neosporin. Everybody's like, now it's just red thing I found in the body. And when I'm lacking, I get crazy. What is it? Oh my gosh.
You're good.
Good thing I'm coming.
I mean, you do you. It's all good. I just
didn't
give the
know.
information, you do with it what you want. Mupirocin is an antibacterial again, prescription. So in my wound world, I do see wounds that have infection that I suspect are strep or staph. And so I may do a little bit of that topically actually on the wound bed in addition to cutting away dead tissue and stuff short term. It's used for MRSA, the more resistant strep, the methicillin resistant staph. And again, that can just live on our skin normally. But because of overuse, I mean, it's prescription, but it still gets overused because you get a tube that's like this. And then after you've got done using it for impetigo, infected skin, you still have this tube, right? Lavelle still has this tube.
Use it.
Use it.
You don't get the pain. Nobody tells you.
Yeah.
They give the medicine and you think another come up. Okay, put it.
Put it. So, right, the frequent exposure to antibiotics leads to more resistance. So we're already using it for a resistant bacteria. And now we're making that bacteria resistant to one of our first lines. We're running out of antibiotics. Ain't cool. Lavelle, knock it off.
Yeah.
It's all your fault.
Yes.
No, I mean, it has its place, but not everything needs it. This silver sulfidine gets used in the burn world. So people up in the burn units or who are being maybe seen in the ER and minor burns. But silver sulfidine gets used because silver inhibits bacterial growth. And of course, you have a burn, you have a loss of your protective barrier. You have all this open tissue and you have a body that's full of bacteria all over it. And so if we can put a topical, it's not an antibiotic, right? It's not going to cause resistance to antibiotics. It just is inhibiting the bacteria that's already there from continuing to replicate. So it's more innocent. Overuse, of course, you're going to start to absorb silver. People who are like Lavelle and might not
Do you have a
put it
cap?
on everything.
I have a Neosporin in my pocket.
So overuse, like real overuse onto an open wound. I mean, that's an area that's highly vascular. You're going to get more absorption. You can end up getting a little bit toxic on silver, but it's rare. We like it in the burn world. We like it in the wound world because it's less likely to cause those resistances. Because of the sulfa base that it's in, we say if anyone's allergic to a sulfa antibiotic, then we don't use it because that's the drug composition. It comes in a sulfazidine base. There is no silver with another base on the market. If you want to get rich, come up with that. And then the adverse effects are just same thing as like Neosporin and anything else that you put on your skin. It's just going to be related to having something on your skin. It's a nice product. All right, The nurse is assessing a patient who's been diagnosed with MRSA on the right arm. What medicine do we anticipate using?
D.
Ooh. So that's tracing, neomycin, polymyxin B, and mupirocin. It is mupirocin. Yeah. It is. And so, yeah, that's what we use for, let's see. We have a picture of the, oh, that's not a good picture, but that's impetigo. Anyone had kids who had that? Kind of, it looks like crusty sores around the mouth and on the face. That's the #1 place it strikes.
Was because they drove a lot. And
And
that's what the doctor told
Is it
me.
from food?
it's a bacterial infection. So it's for whatever reason. We have dry skin and get a crack or cracked corners of the mouth, or kids have dirty hands and touch things. Who, you'll have some break in the skin where you'll end up with an infection. And that's impetigo. So if you ever hear that, impetigo, then we typically use mupirocin on that as well. But once you get it, mupirocin, then just don't use it anymore. All right, acne. So that's all about the topical anti-infectives, antibiotics, and then bacteriostatic, meaning inhibited bacterial growth. So this is what's over the counter, benzoyl peroxide. It's the first line therapy.
You know what's funny though, is the benzoyl peroxide, like over the counter at the store, is like, it's a higher percentage of the medicine in it than a prescription one that you get from the doctor.
I don't know. I know it's usually like 10% over the counter. So
Yeah, and it's like 5 or 3% when you get a prescription, because I've dealt with this literally since I was like less
well,
than 10
and
years.
maybe it's because you're having a lot of the side effects, because it does, because of the way it dries the skin. So acne is caused from the excessive oil secretion in glands becoming blocked, and so you have bacteria trapped in there, and you get inflammation. And so we're trying to dry the skin, give an antibacterial. This is most an antibacterial through the process of just oxidizing it. We break the bacteria by exposing it to oxygen. Nice mechanism that doesn't involve an antibiotic. But it takes a long time of regular use, and that's just for everyday kind of run-of-the-mill acne, teenage acne that's not super severe. Takes very consistent use. Teenagers are not known for consistent use, but it's on the market and it's effective. The drying and the peeling is annoying, but it works. When we get to more aggressive treatments, we start going to antibiotics like clindamycin to more aggressively treat the bacteria. It may be in combination with the benzoyl peroxide. So you may clean your skin with the benzoyl peroxide in order to get rid of the surface bacteria and get rid of the surface oils, so that this medicine can topically get in there and kill bacteria. Same sorts of antibiotics, so we do have a risk of lots of types of localized reactions, but it's not systemic, so you're not going to have systemic side effects. You like to just use it on it. Other antibiotics that we use fall into this class: minocycline, doxycycline, tetracycline, and they are effective. We do know there's some issues with these drugs, and so we want to, these are going to be oral, not topical, so more risks for side effects. And then in women, we know that regulating hormones can help with acne, and so women who have consistent acne that maybe has failed benzoyl peroxide and failed clindamycin, and maybe they don't want to be on an antibiotic, or maybe they failed that, or maybe this is early in the treatment. It's an option to just be on a contraceptive that has hormones, so that those are more regulated. And can we give it to men?
Because gaining weight is so much better than having some acne.
Yeah, choose your poison. Do you want to gain weight?
Like
Or
70
you want
pounds in
acne?
6 months.
Now, when we have this, that's not very good, cystic acne, the one that causes scarring and like pock marks on the face, that's so inflammatory face, it can be on the neck and shoulders, back, upper arms. So then we start moving into the hardcore drugs, isotretinoin. And this is basically they failed all these other treatments, and for some reason they have this super genetic predisposition to scar and to be inflamed. And so we use this prescription medication, and main things are, it actually is cutting down on the secretion of your oils. So hey, if you don't have oils to trap the bacteria, then we might be able to cut down on the acne. It has anti-inflammatory effects, so calming down that inflammatory effects. And this is keeping the skin soft so that we can get in there and clean it. There used to be the Accutane on the market. It got withdrawn from the market, but people still call these drugs Accutane, even though Accutane is not on the market. These are isotretinoin, and I've actually never heard of these brand names because we all call it Accutane. Go figure. So, all right, so now we'll kind of talk about it before we talk about it. A woman who's taking this isotretinoin calls the office to say that she thinks she may be pregnant. What will the nurse instruct the patient to do? Stop the isotretinoin, reduce the dose to every other day, switch it from isotretinoin to tretinoin, or consult their prescriber.
Okay, right?
Stop it immediately. It is pregnancy category X. Yeah, and so there are specific things that people have to do. Women of reproductive age have to jump through hoops. So they have to sign an I pledge saying, I promise I won't become pregnant on this medication, because that's why Accutane got taken off the market. Because it's category X and people got pregnant and had teratogenic effects for the babies and all of that. They have to sign this pledge after they're counseled that they have to use 2 forms of contraception to prevent becoming pregnant. Wow. So, I mean, it's kind of serious because nobody wants to have a miscarriage and they're hoping to become pregnant, but if you're hoping to become pregnant, don't be on this drug. Then there's a million other side effects that come with it, from anything from blood cell suppression, pain, being sensitive to the sun, muscle aches, I mean, lots and lots of issues. But if you have cystic acne, and it can really psychologically impact your life. So I'm glad there is a treatment on it. It does have this caveat to watch for suicidal ideation, increased incidence reported being associated with this drug. Is it from the drug, or is it because you have cystic acne and your life is torture? I don't know, but knowing those things about the pregnancy category X, using 2 forms of contraception, and monitoring for suicidal ideation. So there's tretinoin, and then there's this derivative, or isotretinoin, and then the derivative tretinoin, which is a vitamin A derivative. First came out on the market as Retin-A. And so we use it for acne, and women use it for sun damage and, you know, aesthetically pleasing results. We're trying to get rid of wrinkled skin by causing the skin to peel so that we can have new, fresh skin underneath. That's what it does, is actually just cause the upper layers of skin to peel so that you have newer layers of skin exposed. Fun. It doesn't have this pregnancy type thing because it's topical. Right? It's topical. Yeah, it's topical. It's more of skin reactions, and so a horrible picture, but there's some. This was a picture of an area of skin darkening. So people need to know that if you're going to take this for a while, you have the risk of changes in the pigment of your skin, but luckily it's temporary. It should go away when you stop the drug. But because of the mechanism of action, right, we're causing the skin to peel off. yeah, they should know that you're gonna end up with crusted skin in the process. And you can have blistering and your skin is going to appear red. Like the red crusted skin is how it works.
And you have to protect the from the sun.
Yeah,
It can be the opposite. You can get a really brightly spot.
nice,
Yeah.
nice. So here you are trying to treat your skin, and in the interim, you can't leave your house because you're just all crusted over and peeling and awesome. I think I'll skip it. So that's all about acne. Now, the fungus among us. Fungus is everywhere. Depending on what type of infection it is, it may just be a short-term treatment or it may be a long-term treatment. So two main causes, Candida is a yeast-like and dermatophyte is a tinea or a ringworm type of infection. This is jock itch, which is tinea cruris, so it's going to be more of a dermatophyte type infection there, jock itch. I had to put something for the man.
You see jock itch?
Yeah, jock itch. It's in the, you know, it's in the
Syndrome.
down the jock area. I don't know. That's what it's called. It's itchy because it's, you know, this overgrowth of nastiness, fungus.
Some men don't know how to clean themselves.
And some men don't know how to clean themselves.
Like the majority.
Because you're talking, so I'm gonna accuse you. All right.
You got so red.
It gets too many.
Target you for yakking back there. So here we are, these azoles, antifungals. We're using them topically, whether it's topical on a mucosa, topical in the vagina, topical under the breast, topical on our feet. These are all of the what's kind of available on the market to treat topically. That's for fungus. Now we're going to talk about the topical antivirals. We already talked about the oral antiviral. Anybody recognize acyclovir, right? What do we treat with acyclovir? Herpes, zoster, those two things. So the topical form, people do use it for outbreaks of herpes simplex. I think the oral form is more effective, but it does require, you know, a prescription, and people like topical things, right now. So this is prescription, but they do sell some over-the-counter products that are people use for it, and I don't know how helpful they are. Obviously, it doesn't cure anything. The key to it is early recognition of symptoms, early treatment, so that we suppress the replication. Definitely the systemic drugs are better. What are the two systemic drugs for HSV? One of them's already up here. Acyclovir and its derivative. Acyclovir is the prodrug. Valacyclovir. Right, acyclovir and valacyclovir. 5 times a day and 2 times a day. So those are the two systemic drugs for HSV. Just as a reminder to kind of pull it all together. We've talked about anesthetics before, back in the anesthetics chapter, just to kind of review what they're used for, pain and itch, generally speaking. We use them for lots of things. Sunburns, typically those things contain, those over-the-counter products contain benzocaine. We use prescription lidocaine, this EMLA cream, which is a lidocaine prilocaine combination. We also use it as to numb the skin before treatment. So we may use topical lidocaine here first before we do something on the surface. We may use it first even before we inject lidocaine into an area that we might be slicing into, which is my favorite thing to do. Like slicing things? Yeah, I like slicing people.
I do too.
It's a lot of fun. Don't get on my wrong side.
Really kind of skillful in the
Yeah, we're gonna bring some fun pictures of some of my nasty wounds just to make y'all nauseous.
Oh, yes.
Why not?
Do it. We love it.
I didn't do, I had a good one recently too. Great big piece of dead skin on the back leg and I got to slice that puppy off.
Yeah.
So satisfying. It's like when people who like to pop zits, you know, they feel satisfied. Cutting off dead tissue is what makes me feel satisfied.
You wear a mask so they don't see that you're salivating while you're doing it, right?
I'm smiling, yeah, I remember they're smiling, they're having a nice conversation. What are you cooking for dinner today? Don't char your steak too much, because it looks like a charred piece of steak. All right, so what do we use for itch? So just remembering that pruritus is itch, so antipruritic, knowing those terms, emetic, anti-emetic, pruritus, antipruritic. We love antihistamines. They sell topical diphenhydramine, topical Benadryl to put on itchy areas, and it's pretty effective. That's just grocery store stuff. Corticosteroids, the big crap we sell in the grocery store, that's 2.5% hydrocortisone. I mean, you might as well put Vaseline on your skin. It's not that great, but it's also, I think they allow it to be on the market because you're not going to have the risks associated with real steroids, with the skin atrophy from chronic use, where you can end up with ulcerations in your skin because you've taken a steroid for so long. But they do market it as it, and maybe in some people it is effective to use hydrocortisone. I don't know any real, like, people use it. If it works for you, great. Anything that you put on your face or your skin, just know that the adverse effects are going to be, you know, you can end up with an allergic reaction and redness and burning and dryness, and I like that.
No, like currently.
What's alopecia?
No hair loss.
Hair loss.
You lost your.
So don't, you know, put it on your head. Or maybe for women, you know, just put it up your legs. Kind of like hair. I don't know. Off-label uses for hydrocortisone, I guess. These are the real stuff. So steroids, topical steroids have a great place in therapy. And they come in a wide variety of strengths. If you see something that says like 0.5% and it's an ointment and 0.5% of the same drug and it's a cream, which is stronger, or are they the same?
No.
What is that again?
So say you have triamcinolone, 0.05% ointment and triamcinolone, 0.05% cream. Does it sound like they're the same? But they're not.
The cream
The
is
ointment is stronger. Yeah, because the ointment will actually hold and trap the steroid against the skin. It's like putting saran wrap, you know, that the base of it, an ointment is Vaseline. And so you're really trapping it against the skin. It has a longer period of time to be absorbed. So an ointment is stronger than a cream, even though the numbers are the same.
No, that's the cream.
It's like, if I need a steroid, I always ask for an ointment. Obviously, we talked about this. You'll end up, this is an ulceration here from somebody who just had a spot, whether it was an itchy spot or whatever. They had some leftover prescription steroid from who knows what it was, some rashy outbreak that they had, or maybe they had a little patch of eczema at one time and it never flared again, and they still have this tube of steroid. And so they say, oh, well, I got this, let me put it on this lesion on my arm, and ended up just totally destroying the skin. So it's a real thing. Yeah, and so people who do use steroid long-term, just like oral steroids, when we take people off of oral steroids, they have to be tapered off. Otherwise, you have this rebound surge of everything that you've been suppressing. Same thing with the skin. So anytime someone has been on a long-term topical treatment, if they suddenly stop it, they can have rebound redness and rebound burning at the site where they were applying it. So this just goes to, for you to understand why you tell patients, only use it for as directed. Only use it for as long as you're told to and then stop. And if they ask why, which then you'll know some reasons why.
Your skin will fall off.
You know, you pull up a picture and say, see this is somebody's arm that, you know, they used it for 2 years and they got a hole, or it'll come back twice as bad when you stop. And then we talk about psoriasis. So psoriasis is an autoimmune disease, kind of like rheumatoid arthritis. Unfortunately, we do have great drugs to treat it. We do start topically usually. And again, it's this vitamin A analog that we were using for cosmetic purposes or for acne, works with the psoriatic plaques. Yeah, mild to moderate psoriasis and acne. Pregnancy category X. So this one is an oral med. So pregnancy category X, unfortunately. This is over the counter and is pretty effective. This is old school stuff. Products that contain tar, and I don't know how they just found that out, but probably just from the pre-medicine days when we used products that were around. I don't know if it was the construction worker out with the tar and put it on his dandruff or something, but it's pretty effective. It doesn't have a lot of terrible side effects, so we use it for a lot for the flakiness that comes with psoriasis. So people who have psoriasis, they may have a plaque here on their elbows or on their knees, but they also may have portions of it in their scalp that looks like dandruff, which technically it kind of is. So we can use that to treat that symptom. Or if you just happen to have really resistant dandruff for some reason, just using an over-the-counter cold tar product shampoo will treat it. And it doesn't smell like oil, or it doesn't smell like coal or tar.
I was gonna say, they smell good.
Yeah, I mean, you know, they're all full of,
Are they scented?
everything's full of scented crap. All right, and then just to know about these drugs, because you will encounter them. These are for squamous cell and basal cell skin cancers. There are treatments, 5-fluorouracil or Efudex is the most common one on the market to treat very small basal cell cancers, and it's a long time. So what do you need to know? Anytime somebody's applying it, you should be wearing a glove, because this is an anti-cancer drug, and you don't necessarily, you know, the patient doesn't want to put it on their hands, and you don't either. And it's long-term. It takes 6 to 10 weeks of therapy or longer of applying this consistently. But it's effective, and it avoids a surgery in early cancers when they're caught. Then you don't have to go and have it chopped out. And then there's some other ones for various imiquad and picolimus are out there, depending on the type of cancer, or if you have anogenital warts.
Oh, yummy.
So out there, I would just recognize that these are anti-neoplastic drugs, and anything that has to do with anti-neoplasm, the main question is application is like wear your gloves. Not a big deal. There are herbals on the market. Now, if you have an actual aloe vera plant, there's nothing wrong with breaking off the tip of that and squeezing out some aloe vera for your sunburn. The issue that we get with products is then they get mixed with other stuff that you may be allergic to. So that's why the side effects are there. This is not talking about the real aloe vera plant, it's talking about products. So having an allergic reaction or developing itchy skin in the area. And
Is it?
Yeah.
Some people be allergic to like the actual aloe vera.
I mean, I'm sure somebody can, but it's less likely than all of the additive ingredients in the product. And I guess there's oral aloe vera, not oral topical aloe vera.
Juice, right?
Well, could be juice. Who knows if it's really juice? Aloe vera juice. Maybe I've seen aloe vera supplement, and you take orally. And there are drug interactions, you can be sure. And then I could know about topical echinacea because people do use it for herpes and for open wounds, thinking, okay, well, it's not an antibiotic and, this is gonna be easier. But again, you have the same risk of anything that you put on your skin can cause an allergic reaction. I think topically it's less problematic than when you take it orally. On Monday, I have mentioned on one of the slides to please review that section on echinacea. Because for some reason, like St. John's wort before echinacea is the thing that they like to ask you about for the herbal in this section. All right, one last thing and then you're done. Pick a piece of paper and write down what's the main indication for each of these drugs. Some of you should recognize, a couple of them you may not. But I'm throwing them in now so that you will recognize it if it pops up in the future. Take a couple of minutes to 2, 4, 6, 7 of them. Or less. You can do any way you want. You can do it on a sticky note on your laptop. Who else had a note that I needed to collect the signature from? I forget, there were 4. Oh, mine. You're fired. Okay.
Version of acyclovir that is for HIV and AIDS.
No, because it's not a virus. That's a retrovirus, which is different.
Okay.
Well, if they have an opportunistic herpes infection, then they may be using it, or they may be using it suppressive for opportunistic. Like, I would say a lot of people walk around with an HSV infection and never have an outbreak. You have to kiss a lot of frogs and you end up with herpes. Isn't that the saying? A lot of people are carrying it. So it's like an opportunistic infection in an immunocompromised host, but specifically like to treat HIV itself, like that's not the drug to treat HIV, that's the drug to treat opportunistic infections.
Okay.
Yeah, sorry,
Thank you.
that's a better way to think about it.
Everybody got them? Or you still kind of almost? Okay. Have we got them? Yeah, no. Some people are more haste than us anxious people who get it done really fast. All right, so what's povidone iodine used for? Antiseptic to prevent infection, right? So like pre-surgery and all that stuff, right? What is clotrimazole? So antifungal, right? All that type of stuff. Any type of the fungus. Well, not any type, but a lot of them. What's minoxidil? Right. So it orally has a different indication than topically, which is how we found out about the topical indication of hair growth. So used topically for hair thinning. Clindamycin.
Bacterial infections.
Right. So topically, we use it for acne, right? That's one of the like second line treatments for acne. Ooh, the fun one, lindane.
Scabies and lice.
Lice. So everyone can have lice. It doesn't mean you're a dirty person. The cleanest families have kids come home with lice. Just know that there's treatment, and the treatment is becoming resistant because we're so grossed out by the lice that we don't thoroughly complete the treatment. So then you have to get a prescription product. Bacitracin.
Infection of minor cuts, burns, and scrapes.
Topical what?
Biotic.
Antibiotic, anti-infective, right. All right, last but not least, acyclovir. Did you need somebody?
Can I just interrupt really quick?
Sure.
So if you guys haven't received this email, if you will get onto this QR code and take the survey, it's gonna, it helps your cost of attendance. So they do this survey every year. It's really important. It's pertains to your financial aid, it'll benefit you if you take it. We have to have it done by this evening, so if you guys can just do this today sometime. You will also be entered into a drawing of $100 gift card if you do it. So,
So not only lower tuition,
yeah.
but we're gambling. Awesome. Acyclovir is antiviral. Guys are smart. Wow, really. So that was that. Yep, you got it, all of those. Pediculosis lice, the more common use for that one. Yeah, you got it. And women use minoxidil as well because women have hair thinning, but it's our men who lead the way. And this is just, it's in the book, but my plug on wound care, because everyone will assume you as a nurse know everything about wounds.
And I was like, can you look at this? And I'm like, I know nothing.
I know,
about
you
that.
don't
I
learn
worked
about
in wound
wounds
care.
in nursing school, nothing.
I
So,
mean, you do a little bit of it, like if you go to legacy for your foundation. that's-
well, I mean, you might learn
Yeah,
what
that's what I'm
somebody
saying,
is doing, but what somebody is doing may not be what is actually like correct.
Right.
So, people slap all sorts of things on wounds, and it's not necessarily what we put on the wound that cures it as what we do to address the root cause of it or the contributing factors. If you have a pressure ulcer, then the treatment is get rid of
The
pressure, right? And what we put on of it is secondary to everything else. The dressing isn't magic. If it's draining a lot, you put something on it that absorbs drainage. If it's dry, you put something on it that provides moisture. If it looks like it has excess bacteria on it, you put something on it that treats the bacteria. You go and look in Mabel's medicine cabinet for some acitracin, right? And so if it's a diabetic foot ulcer, it's just not what we put on the wound. It's you go back to the root cause. How well is your diabetes being treated? What was your A1C? I don't know. I've been to the doctor in 10 years. And it's because their A1C is 12 or 14 or something like that, that their diabetes is out of control. Yes, you do have to put something on the wound. If it's a dry wound, you put moisture. If it's a wet draining wound, put something that's going to absorb moisture. People who have diabetics on the soles of their feet have to stop walking. They have to stop walking because it's a combination of their underlying disease and the pressure from walking. And they don't want to do it. And sometimes we put them in a total contact cast, which actually is casting them like a broken bone, but we leave an area to relieve the pressure under the ulcer so that when they walk, because everybody will, that pressure is relieved. And that contact cast has to get changed pretty frequently. It's a very invasive thing. Or you put them in a post-surgical shoe, one of those ones that are really rigid with a really hard sole, so it makes it really uncomfortable to walk. And so we think that'll encourage them not to step on it, but they just take the shoe off. So it's tough. So what we put on it is not as important as treating the cause and the prevention. And remember, you can get pressure ulcers from, I've seen it on oxygen tubing behind the ears. You can get it from somebody laying on their urinary catheter. So it's not always on a pressure point of the body. It can be because there was pressure somewhere else. And obviously we want to prevent it from happening again. And this, like I say, my most favorite thing to do is surgical debridement. If you leave a wound alone and a person is otherwise fairly healthy, so leaving it alone meaning that you cover it. And if it's a dry wound, you cover it with something that provides moisture. If it's a wet wound, you cover it with something that absorbs. So basically covering. It is not what our parents taught us to leave it open to air and let it breathe. Okay, wounds don't have lungs, wounds don't breathe. We don't leave it open to air. We don't want to dry out tissue. Tissue that dries out dies, is dead. We want to have a moist wound not too moist, because then it's macerated like when you bed in the bathtub and you have wrinkly raisin fingers. That's not healthy either. If you leave it alone and leave it covered and change the dressing at appropriate intervals, our body has enzymes to break down the dead tissue on its own. It's slow, but it's the most natural way to do it, the most cost-effective way to do it. So oftentimes that's what I'm doing. Maybe not if there's a huge amount of dead tissue, but if somebody comes in with a wound that has a mild amount of this yellow slough, depending on a lot of factors, if I don't take a scalpel and cut it out, that's the treatment. Just cover it, change at appropriate intervals, which is if it's a wet wound and you're absorbing, you change it when the dressing is full. And that can vary from week to week. If it's a dry wound, you put it on there and you keep it on until the wound is, when you take it off, the wound is dry and it's not providing moisture. There's not a set interval of time to change your dressing. People like to write orders and say, change it 3 times a week. There has to be a justification for 3 times a week. Why does it need to be 3 times a week? And it can change from this week to next week. You may have a lot of drainage in 1 week, and then the next week have very little. So you are going to now be the knowledgeable nurse who says, that wound is leaking a lot of serous fluid. I need to put something on it. Here's your wound bed. Here's your wound, a little bit of necrotic material in the center and in there. So you want to protect the edges. So you can either put skin prep around here to help the dressing adhere. I happen to use a specific brand of a barrier cream. I use calmoseptine, which is just a baby butt cream. It's the pink one. This is my practice, doesn't mean it's the only way to do things. I apply calmoseptine on a highly wet wound, even a wet wound, around the edges. Why do you think I would do that? Why would I put a cream around the edges?
Protect from maceration.
Yeah, protect the edges from maceration. Just like why do you put diaper cream on a baby? To protect the baby's butt from the moisture and the acid coming from their urine. Same idea. You're protecting this fragile skin because when the tissue heals, it heals this way from the edges in. It doesn't just suddenly grow an island of tissue right in the center. Wounds heal from the edges in. And if you have unhealthy edges, it's not going to heal. So I like to put a little bit of, I have my cotton tip applicator, a little calmoseptine around there. All right, now my edges are protected. All right, is it an exudating wound? Is it producing lots of exudate fluid? It could be serous fluid, it could be bloody fluid, it could be purulent fluid. Whatever it is that you're doing to absorb that fluid, you choose whatever dressing is on the formulary. Basically, it's whatever absorbs. And there's lots of products that absorb, and some absorb more than other, and some are super highly absorbent, and there's all kinds of varieties. But as long as it absorbs, it's doing its job. So you put something that absorbs over it. And if it's a product that happens to have a surface and then a backing on it that adheres, that's even better. Okay, now you have a dressing that, it's one of these standard foam dressings, and on the back is this plastic with a silicone sort of adhesive around it. And so, okay, this one's small, so it wouldn't fit that wound, but you want that to cover the wound bed, be big enough to cover it. This is now sticking where you applied skin prep so that you don't have irritation from the adhesive. Because people get lots of rashes from the adhesives and they get skin tears when you pull it off. So now we've adhered this where we have the skin prep around here. Yeah.
If someone's allergic to adhesive, can you still use that?
It depends on, because adhesives are different adhesives. I have a patient who's really sensitive to a lot, and we just have to do trial and error. We found that with her, we can use paper tape, but we can't use cloth tape or plastic tape. So, and we can't use any adherent dressings. We would just use like the foam, and then we would, just secure it with some tape on there, paper tape. And it doesn't stay as long, but it works better for them. Wet to dry is actually a method of debridement. So debridement means removing dead tissue from the wound. So you put a wet gauze, get some gauze and you saturate it with saline and you squeeze the excess out. Not really squeeze it, but squeeze most of it out and you apply that to the wound bed. And then you put dry gauze over the top and then you take that down. And then you come back a few hours later when the gauze that was on the wound itself was wet, it's now dry and it sticks to the wound bed. And you yank it out and you tear out all the dead tissue. That's the purpose of wet to dry dressing. It is a debridement and you have to do it frequently and it's painful. So the only place I've ever seen wet to dry used is in the hospital because it's cheap. It's just, there are better things now. It's a wet wound, absorb. It's a dry wound, put moisture. We have one product on the market that is actually a papaya enzyme. It's an enzyme from papaya fruit. The product is called Santo. If you're interested, there's no test question on it. Unfortunately, this has to be done every single day. And so we teach people to do their own care at home and we follow up with them, but they have to do the same sort of skin prep because it's an enzyme. And now we don't want to put an enzyme that eats away at our healthy edges of our wound. We're trying to get rid of this dead tissue. So this is all talking about getting rid of dead tissue in the wound. So we've let it do itself. We've yanked it out. We've used an enzyme, and with this one, then you put gauze over it and tape, and just it's changed every single day. And you get it changed from really firmly stuck on slough. It starts to melt. It kind of looks like candle wax. It just breaks down the fiber in it, and it gets cleaned out easier and easier. And you stop when the wound is clean. And then, of course, you can have a number 10 blade. You can have a dermal curette, you can have scissors, all kinds of stuff to cut it on out. And sometimes that's just the most appropriate thing. The only thing is anytime you have dead tissue, so you have a patient with vascular disease, this is their foot, this is a Fred Flintstone foot, and they have a heel ulcer here from lying in bed, and the tissue's all dead, and it has black, like a scab, called eschar on it. This is the one time you don't take it off. You leave it alone. In this particular case, this dead tissue is acting like a bandage. You treat the underlying cause. Is this a pressure ulcer? All right, we elevate under the calves to float their heels. Is this a vascular ulcer? They don't have arterial blood flow. Well, then they need to see a vascular surgeon in order to talk about blood flow. They have a combination of things, you address it all. This is just for your information. There's no test on this at all. But this type of black eschar on here, on the heel, you just leave it alone, so you don't debride it. That's all I got. You now know everything I know.
Do we though?
You are free to depart. You are free to study for all your good stuff you got, your Monday Hussey in your other class.
Yeah. I've almost got it all out. And sometimes it's harder to do it when you're by yourself. I like to study other papers and it like helps me things really understand.
Good luck.